Welcome to AETCM, the emergency medicine channel. Today let's discuss regarding the drugs that are used in ACLS. So we know already what differs APLS from ACLS is the usage of drugs and usage of the advanced airway management techniques and by performing defibrillation and cardioversion. So rest remaining things we can perform in BLS, but here we will be using the drugs, defibrillation and followed by advanced airway management things. So that is the difference between BLS and ACLS. Now in this today's session we will discuss regarding the most common drugs that we will be going to use in our ACLS, that is especially in the case of cardiac arrest, bradycardia and tachycardia algorithms. Okay, so first thing is the first most important drug that we will use is adrenaline. So let us discuss regarding this adrenaline. So adrenaline, it is usually a vasopressor or a catecholamine drug. So the availability of this adrenaline is usually 1 mg in 10 ml, that is 1 mg per 10 ml, 1 in 10,000 dilution. Usually we will be pre-filling it, or usually it will be 1 mg over 1 ml. Okay, that means 1 mg, the most common form of availability of adrenaline drug is usually it will be 1 ml, and each ml contains 1 mg of adrenaline, which is equal to 1 in 1000 dilution. So this is the most common form of availability of this adrenaline. So next thing is why we have to use this adrenaline in the case of, especially in the case of cardiac arrest. So it is to restore spontaneous circulation. That is, we know one thing that is called as return of spontaneous circulation. So what is return of spontaneous circulation? Return of spontaneous circulation is nothing but it is reappearance of pulse and breathing. So we will be performing CPR. So after some times the patient might attain return of spontaneous circulation. So to attain the return of spontaneous circulation, especially in the case of cardiac arrest, we will be using this adrenaline. Why? After giving adrenaline, the chances of return of spontaneous circulation will be high, and it will improve the blood circulation. It will improve the circulation to the heart and brain. So that's why we are using this adrenaline in the case of especially cardiac arrest. Okay. So when to use, especially in the case of cardiac arrest, we know we have two shockable rhythms of the cardiac arrest and we have two non-shockable rhythms of the cardiac arrest. So what are the shockable rhythms of the cardiac arrest? That is pulseless ventricular tachycardia and ventricular fibrillation. These two are the shockable rhythms of the cardiac arrest, and we have two non-shockable rhythms of the cardiac arrest, that is pulseless electrical activity and asystole. Okay. So in these two situations we will be using this adrenaline. So in the case, first we will see these shockable rhythms of the cardiac arrest. In the shockable rhythms of the cardiac arrest, after performing second defibrillation, you need to give a drug that is called as adrenaline. The dosage of adrenaline is, we have already discussed, that is 1 ml, 1 mg, 1 in 1000 dilution. So after performing second defibrillation, you need to give this adrenaline drug, and it has to be repeated for every 3 to 5 minutes. That means every fourth minute you need to deliver this drug, that is adrenaline. So who has to deliver this drug is the person who is taking care of the medication administration. He has to deliver this drug, and it has to be repeated. Okay, then that is for shockable rhythms of the cardiac arrest. And next thing is, if the patient is having non-shockable rhythms of the cardiac arrest, as early as possible we need to deliver this adrenaline. Here also the same dosage is same, that is 1 ml, 1 mg of adrenaline, 1 in 1000 dilution, and it has to be repeated for every 3 to 5 minutes. That means at every fourth minute we need to deliver adrenaline drug, and we have to look for the reversible causes of the cardiac arrest. So mechanism of action. Next thing is mechanism of action. Primarily, why we are giving this adrenaline in the case of cardiac arrest is mainly it will act on the alpha-1 receptors that are present in our body. That means these alpha-1 receptors, usually it will be present on the vascular smooth muscles, which will be causing massive vasoconstriction, and finally there will be increase in the blood flow to the heart especially. So that's why we have seen here it will increase coronary perfusion pressure. And it has one more action. It will be mainly predominantly it will be acting on beta 1 receptors. So where all these beta 1 receptors are present? These beta 1 receptors are present on the myocardium of the heart. So we know the layers of the heart: epicardium, myocardium and endocardium. So after giving this adrenaline drug, it will go and it will act over the myocardium of the heart, which will cause improvement in the contractility of the heart. So conduction system will be improved and contractility of the heart will be improved. So that's why we are using this adrenaline. So dosage we have already discussed. It is very simple, that 1 ml 1 mg of the drug, either intravenous route or intraosseous route we have to deliver, and it has to be repeated for every 3 to 5 minutes. If it is a shockable rhythm of the cardiac arrest, after second defibrillation you need to deliver this adrenaline, and rest it has to be repeated for every 3 to 5 minutes. And if it is non-shockable rhythm of the cardiac arrest, as early as possible we have to deliver the same dosage of this adrenaline, and it has to be repeated for the next every 3 to 5 minutes. And in one more use, that is symptomatic bradycardia. So in the symptomatic bradycardia we can give this adrenaline as an infusion, but the treatment for symptomatic bradycardia is usually atropine. The maximum dosage of atropine that we can give is 3 mg. Even if the atropine is not working, then we can go ahead with transcutaneous pacing. Even though the patient improvement is not there, then we can start with this adrenaline infusion. The dosage of adrenaline infusion, especially in the case of symptomatic bradycardia, is 2 to 10 microgram per kg per minute infusion. Okay, so these are all the certain dosage regimens that we need to use for the adrenaline. The next thing is precautions. It is very high alert. We have to make sure that once after giving the adrenaline, at least 10 to 20 ml of normal saline flush needs to be given. So then it will reach the circulation faster and it will have its best effects to the patient. So I hope you understood something regarding the adrenaline. So main thing is we will be using this adrenaline as a most common drug, especially in the case of cardiac arrest, and we have lot of uses of adrenaline that we are not going to use in this thing. We are mainly focusing on ACLS. Okay. The next second drug is amiodarone. We know it is an antiarrhythmic drug, that is class 3. So arrhythmia is something which is an abnormal rhythm, so it will act against to the arrhythmia, so that's why it is an antiarrhythmic agent. So availability, so 150 mg over 3 ml it will be there, so we can give it as a bolus or infusion dose. So why it is used especially in the ACLS is to suppress recurrent or refractory ventricular fibrillation, okay, or tachycardia. So this point is very important, to suppress recurrent or refractory ventricular fibrillation or tachycardia. So I have told you when we are discussing regarding the adrenaline, I told you we need to perform second defibrillation. So after performing second defibrillation only we need to give adrenaline drug. Okay, then we have to continue CPR. Then after performing, after 2 minutes again we need to check for pulse and breathing. If both of them are absent, again we need to perform third defibrillation. So after performing third defibrillation, even though if the rhythm is not reverting back to its original state, then we need to give this drug that is called as amiodarone. Okay, so it's an antiarrhythmic agent when we have to give after third defibrillation. So after third defibrillation we need to give this drug that is called as amiodarone, but the dosage of this amiodarone is 300 mg. Okay, for the next dosage we might give as 150 mg also. So this is the dosage of amiodarone. So we have discussed the mainly why we are using it to suppress recurrent or refractory ventricular fibrillation or tachycardia. Then when it is used in that is, so cardiac arrest especially we have already discussed in the previous slide. It is when we have pulses, ventricular tachycardia or ventricular fibrillation, then we need to give it. And also we can use it in the case of stable wide complex tachycardias. Okay, in the stable wide complex tachycardias also we can use. That means if the patient is stable without signs of instability, the patient is having tachyarrhythmia, then we need to control the heart rate and we need to control the rhythm also. So that's why we will be giving in the case of stable wide complex tachycardias also. So next we will see the mechanism of action. So what it will, where it will act is, it prolongs the action potential duration and refractory period in myocardial tissue by blocking potassium channels. So by blocking potassium channels, it will prolong the action potential duration and refractory period in myocardial tissue. And one more thing is, it will slows down the conduction between SA node and AV node. It will slows down the conduction between SA node and AV node. We know already that SA node is the natural pacemaker of the heart, where the impulse will be generated, then from SA node to the impulse will be generated, where in SA node impulse will be generated and it will be traveling through AV node. So this, it will slows down, this conduction system will be slowed down by amiodarone. Okay, dosage in so that is the thing, mechanism of action. Then dosage, especially in the case of this ACLS, is, in the case of cardiac arrest, I told you it is 300 mg. When we have to give that, after performing third defibrillation, we need to give amiodarone 300 mg as a bolus, and for the next subsequent dosage we can give 150 mg as a bolus. So we have discussed one more thing, that is wide complex, wide stable tachycardias, whatever it may be, narrow complex or wide complex, whatever it may be the tachycardia or tachyarrhythmia, if the patient is stable, we can try all the drugs like beta blockers, calcium channel blockers, or everything, but at the end this is the safer drug, we can go ahead with the amiodarone, but dosage will vary here. In the case of cardiac arrest, it is 300 mg followed by 150 mg, but here it is first 150 mg over 10 minutes, 150 mg over 10 minutes followed by 1 mg per minute for the next 6 hours, followed by 0.5 mg per minute for the next 16 hours. So this is the infusion dosage of amiodarone. So precautions what we need to take is, the rapid administration in the case of stable patients can cause severe hypotension, and it must be mixed with dextrose water for the infusion. So just make sure that give it slowly, sometimes it may cause hypotension. So this is about our second drug, that is called as amiodarone. It's an antiarrhythmic agent. We'll use this amiodarone in the case of cardiac arrest after third defibrillation, 300 mg followed by 150 mg. In the case of stable tachyarrhythmias, we will be giving amiodarone 150 mg over 10 minutes followed by 1 mg per minute for the 6 hours, followed by 0.5 mg per minute for the next 16 hours. Okay, next drug is lignocaine. Lidocaine, this is IV preparation. We will be calling it as xylocod also. The class is, it is also an antiarrhythmic agent. It's a class 1B antiarrhythmic agent. Availability is 100 mg for 5 ml pre-filled syringe or 2% solution in vial. So this is 2% solution vial. It is most common thing that we'll usually see. And why it is used in ACLS is, same thing, it will work as amiodarone only to suppress ventricular arrhythmias, and it will be used as an alternative to amiodarone. For suppose, I have told you already, we have to give amiodarone after performing third defibrillation, but if you don't have amiodarone in your workplace, then you can go ahead with this IV lignocaine. Okay, then when it is used, especially we can use this in cardiac arrest, that is shockable rhythms of the cardiac arrest, pulses, ventricular tachycardia or ventricular fibrillation. If you won't have the drug that is amiodarone, then we can go ahead with lignocaine. Okay, then mechanism of action, it will decrease the cardiac excitability by blocking fast voltage gated sodium channels. So this is the mechanism of action. And dosage in the case of ACLS, especially in the case of cardiac arrest, the IV or intraosseous route of drug administration dosage is, initially you can give 1 to 1.5 mg per kg body weight of this lignocaine as a bolus, followed by next dosage is 0.5 to 0.75 mg per kg body weight, and maximum you can deliver is up to 3 mg per kg body weight. Okay, precautions, toxicity risk, symptoms include, we can see altered mental status, seizures and tinnitus. It's a kind of sound that it will be produced in the case of ears or head, and dose must be reduced in patients with liver dysfunction. So already it will cause hepatotoxicity and all. So make sure that whenever if you are having a patient with liver dysfunction, and you have to reduce the dosage of this lignocaine. The maximum that can be given is 3 mg per kg body weight. So this is about lignocaine. It is an IV preparation. We will be calling it as xylocort. So when we have to give this one is, if you don't have amiodarone in your workplace, then you can consider this lignocaine. Dosage is 1 to 1.5 mg per kg body weight, followed by 0.5 to 0.75 mg per kg body weight. And the next drug is adenosine. Adenosine, it's an antiarrhythmic agent. So again, availability 6 mg in 2 ml pre-filled syringe or vial it will be available. So why it is used in the case of ACLS? Especially the main usage of this adenosine is it will slows down the conduction between SA node to AV node. We know already that SA node is natural pacemaker of the heart, where the impulse will be generated, then it will be traveling to AV node. From AV node it will go to bundle of his, then right and left bundle branches, then ultimately the impulse will be going into Purkinje fibers. So in order to slow down the conduction between this SA node to AV node, we will be giving adenosine. Okay, hope it is clear. Then mainly to slow the conduction through the AV node, chemically terminates supraventricular tachycardia. The only drug that we will give in the case, so it is mainly given in patients with supraventricular tachycardia. So we know what is supraventricular tachycardia. Usually it is a narrow complex regular tachycardia with an embedded with absent P waves. So that is supraventricular tachycardia. So in these conditions, to slow down the conduction between SA node to AV node, we will be going ahead with this adenosine. Okay, the dosage of adenosine that we will discuss. So before giving adenosine, if the patient is having stable tachyarrhythmia, that is stable narrow complex regular tachycardia without P waves, that is your supraventricular tachycardia, at that moment you can give adenosine. But before giving adenosine, you can perform carotid sinus massage. So if the patient is not, if the heart rate is not improving, then you can go ahead with this adenosine. Okay, clear. So when it is used, we have already discussed stable narrow complex supraventricular tachycardia. If it is regular and monomorphic, then we can use this adenosine. Mechanism of action, it will temporarily blocks the AV nodal conduction, and chemically it will reset the AV node. So that's why we are giving this adenosine. Dosage in the case of ACLS is, you can give it as a rapid IV push. Okay, that is very important. I will tell you why we have to give it as a rapid IV push. First dose of the adenosine is 6 mg. 6 mg over 1 to 3 seconds. This is very important. So next dose is 12 mg over 1 to 3 seconds. Okay, the dosage of adenosine is 6 mg followed by 12 mg. So over 1 to 3 seconds we need to deliver, because the half-life of adenosine is very short. Some books, most AHA also says that it will be less than 10 seconds only. So first you give 6 mg of adenosine. After giving 6 mg of adenosine, you have to make sure that already you should have the tray, everything should be already readily placed, and immediately you need to push 20 ml of normal saline, and you need to elevate the limb. So if you elevate the limb, then only the drug will reach into the circulation faster, because the half-life of adenosine is very less. So first you try with 6 mg of adenosine, check whether the rhythm is reverting to its normal or not. If it is not happening, then you can give 12 mg of adenosine. Okay, if the patient who was already having central line which is in place, then half of these dosages are enough. That means first dose you can give it as 3 mg, then followed by 6 mg. Okay, if the patient is having central line, so if the patient is having central line, then you can deliver this dosage. Okay, then precautions, what we need to take care is, So it should be given as an extremely rapid IV push followed by immediately 20 ml of normal saline flush, and we can expect a brief period of asystole. So this is about adenosine. It's an antiarrhythmic agent. So when we have to give adenosine mainly it is indicated in patients who are having narrow complex regular tachycardia without PVS, and the patient should be stable. So the choice of medication is adenosine. So before giving adenosine, we can perform carotid sinus massage. Even though if the patient is not improving, then you can go ahead with adenosine. The first dosage of adenosine is 6 mg. The next dosage is 12 mg. If the patient is having central line which is already in place, then you can give half of the dosage of adenosine. But make sure that once after giving adenosine, we have to flush it with 20 ml of normal saline flush, and we have to elevate the limb. Then only the drug will reach into the circulation faster. Okay, this is about adenosine. And the next drug is atropine. It's an anticholinergic parasympatholytic. Availability is 1 mg per 10 ml pre-filled syringe, or 1 mg per ml, or it will be like 1 ml 0.6 mg. 1 ml 0.6 mg. So most common availability is this one. So we can see this 1 ml which is 0.6 mg. Then why it is used is to increase the heart rate, to increase the chronotropy. We will be using this atropine especially in the case of this ACLS, and AV conduction velocity. When it is used in the case of symptomatic bradycardia. That means if the patient who are having unstable bradycardia, then we have to give this atropine, especially in the case of this bradycardia algorithm. So we know what are the signs of instability. The patient can have chest pain, the patient can have hypotension, chances of heart failure, altered mental status. All these things, if the patient, any of these things is there, and if the patient is having bradyarrhythmia. What is bradyarrhythmia? If the heart rate of the patient, if it is less than 50 beats per minute, then we can say it as bradyarrhythmia. If the patient is having all these things, then we have to give atropine. Okay. Then mechanism of action, it blocks the effects of vagus nerve, acetylcholine at the sinoatrial node and atrioventricular node. So automatically it will be increasing the heart rate. Dosage in the case of ACLS, so we have discussed, it is mainly given in patients who are having symptomatic bradycardia. The dosage is 1 mg IV or intraosseous route of drug that can be delivered, and it can be repeated for every 3 to 5 minutes. And the maximum dosage of atropine that we can give is 3 mg. It is for symptomatic bradyarrhythmia patients. Okay, precautions: do not rely on atropine for severe blocks below the AV node. Okay, if the patient is having heart block which is below to your AV node, then we have to be very cautious during that situation, especially in the case of third degree heart block. What is third degree atrioventricular block? There will be atrioventricular dissociation. So in those conditions, atropine may not be the good choice, or it may not be effective in increasing the heart rate. Okay, whatever it may be, we have to give an expert consultation. We need to shift the patient to the cath lab for transvenous pacing, and so that's why we may need to have the usage of pacing. So this is about atropine. It's an anticholinergic parasympatholytic drug. So availability, most common availability is 0.6 mg in 1 ml. So we have to, in the case of symptomatic bradyarrhythmia patients, we have to deliver 1 mg of atropine in over 3 to 5 minutes, and maximum dosage of atropine that can be delivered is 3 mg. Okay. Next thing is magnesium sulfate, and this is last drug. It's an electrolyte or antiarrhythmic agent. So the availability is 1 gram or 2 gram vials. Often it will be supplied as 50% solution. Then why it is used in the case of ACLS is to treat specific ventricular arrhythmias related to the prolonged QT interval. So usually in the cases where ventricular arrhythmias, there will be prolongation of QT interval. In those conditions, mainly we will be using this magnesium sulfate. So when we will be using, especially in the case of cardiac arrest, especially if you are having torsades, deep pointers, What is Torsades D pointers? How the ECG of Torsades D pointers will be there? It is actually an irregular, it is actually wide complex irregular tachycardia without P waves, and there will be twisting of the waves around the axis. Twisting of the waves around the axis. So that is called as Torsades D pointers. If that condition is there, then we need to give this drug. Or suspected hypomagnesemia or Torsades D pointers with a pulse, we will be going ahead with giving this magnesium sulfate. Mechanism of action, it slows down the SA node impulse formation and it prolongs the conduction time. We have already discussed the conduction time will be prolonged by giving this drug, and it will slows down the SA node impulse formation, and it acts as a physiological calcium channel blocker. So dosage in the case of ACLS is, in the case of cardiac arrest, Torsades D pointers, so 1 to 2 gram IV diluted in 10 ml or dextrose normal saline, and we can give it as a rapid push. The dosage of magnesium sulfate is 1 to 2 gram IV. We can dilute it in with 10 ml normal saline or dextrose, and we can give it as a rapid push, and this is especially in the case of cardiac arrest. So we have already discussed two shockable rhythms of the cardiac arrest. In that, if the patient is having Torsades D pointers, that is twisting of the waves around the axis without pulse, then we can give 1 to 2 gram magnesium sulfate, and it can be diluted in 10 ml. Then Torsades D pointers with pulse, we can give 1 to 2 gram of magnesium sulfate diluted in 50 to 100 ml normal saline, and it can be given over 5 to 20 minutes. In the case of cardiac arrest, we can give it as a rapid push, but in the case of Torsades D pointers with pulse, then we can give it, the 1 to 2 gram can be diluted in 50 to 100 ml normal saline, and it can be given over 5 to 20 minutes. So precautions, the rapid infusion can cause hypotension or bradycardia, so must monitor for signs of magnesium toxicity, that is loss of deep tendon reflexes and all. So this is about magnesium sulfate. So these are all the most common drugs that we will use, especially in the case of ACLS scenarios. So